My name is Dr. Anna Lev-Towoff from the Department of Radiology at the Hospital of the University of Pennsylvania. This presentation will review the sonographic evaluation of intrauterine devices. Worldwide, IUDs are the most commonly used reversible contraceptive method. The use of IUDs in the United States is also increasing, both for contraception and for local progestational effect. Sonography has an important role in the evaluation of IUDs to confirm the correct position and to assess for complications. Therefore, imagers need to know normal and abnormal appearances of IUDs. The objective of this presentation is to review the types of IUDs and normal and abnormal sonographic appearances, to discuss the role of 2D and 3D ultrasound, review the pitfalls and artifacts related to IUDs, as well as the complications. The indications for the use of IUDs includes reversible contraception in women with at least one full-term pregnancy, the treatment of endometrial hyperplasia, as part of a hormone replacement therapy regimen by providing local progestin in combination with estrogen given by another means, as well as more recently the treatment of excessive uterine bleeding, be it idiopathic, adenomyosis, or small fibroids. These are the two IUDs that one is most likely to encounter in clinical practice. On the left is the copper-bearing Paragard IUD, which has a T shape, and on the right is the plastic Mirena IUD, which contains progesterone. Note that the horizontal upper arms of the Mirena are angled inferiorly at their distal tips. There are three types of IUDs: the inert, the copper-bearing, and the hormone-containing. Of the inert IUDs, there are the plastic polyethylene IUDs that are impregnated with barium for radio opacity. Some of these are of historic interest, such as the Lippy's loop, which one may still occasionally see in an older woman, the safety coil, and the old Dalcon shield, which was very problematic. A widely used inert IUD is the stainless steel ring that is very widely used in China. And this is an image, a multiplanar image of the stainless steel IUD. This IUD is not as effective as the IUDs that are most commonly used in the United States. Here we see the ring in the coronal plane. In this case, a pregnancy occurred, and we see that the IUD here, represented by these two echo densities, is adjacent to the gestational sac. Note the ring down artifact that traverses the gestational sac from the metallic ring. Here is the Lippy's loop. In the coronal plane on a 3D image, we see the serpiginous course of the Lippy's loop, and the typical clue to this IUD on 2D sonography are the 5 echogenic foci aligned in a straight line with shadowing. Now, of the copper-bearing IUDs, the most common that you're likely to see is the Paragard T-shaped IUD, which is available widely in the United States and is effective for 10 years. One may see also the copper 7 IUD. Now, these copper IUDs have highly echogenic straight shafts or vertical portions, and they have crossbars that are also highly echogenic and that form the shape of a 7 or a T. The copper-bearing IUDs cause their effect by a local increase in copper levels, which leads to decreased sperm motility, irritation of the endometrium, and possible ovicidal activity. Finally, the hormone-containing IUDs are used for contraception, endometrial hyperplasia treatment as part of hormone replacement therapy, and the treatment of menorrhagia and anemia. Of these, a most likely one encounters the Mirena, which includes a synthetic progestogen, levonorgestrel, which is highly effective for 5 years. Another one is the Progestasert. Now, the Mirena IUD is T-shaped, plastic polyethylene with barium sulfate for radiopacity. It measures 32 millimeters in length and 32 millimeters across both of the arms. Remember that the tips are angled down at the end, so this should not be confused for fragmentation. Now, the vertical stem of this IUD has a reservoir containing the hormone and is thicker than the remainder of the IUD. The characteristic appearance of the Mirena is that only portions of this device are highly echogenic, unlike the copper IUDs. So the Mirena can present a problem with imaging. The earlier versions of the Mirena were very difficult to visualize sonographically, and I'll show you examples of that. And the string could actually be more echogenic than the IUD itself. The more recent versions are more easily identifiable. The vertical shaft is more echogenic, and the IUD string is slightly less echogenic. The horizontal arms with their characteristic downturn distally are still difficult to image. So again, this is what the IUD looks like. The contraceptive effect is mostly due to the local effect of progesterone. Women that are of fertile age still have ovulatory cycles with follicular rupture. The other thing to note about this IUD is that the atresia of the follicle may be delayed because of the progesterone, and the follicle may continue to grow, so that enlarged follicles have been found in approximately 12% of women using the Mirena. What are the reasons for referral for ultrasound in women with IUDs? Commonly, the thread is no longer visible or palpable, and there is concern about expulsion or a broken thread or retraction into the uterus. Also, there may be a clinically apparent change in the length of the thread, which suggests the possibility that the device has become displaced. Now, increased menstrual flow, especially after a period of time where the flow has become diminished, which is what one expects, may be a clue to expulsion. Pain raises concern for embedment. There may be signs and symptoms of infection, or the patient may present with amenorrhea, which could be a sign of concerning for pregnancy. What is the technique that we use to evaluate these patients? We routinely do take a quick look transabdominally, but usually this is not sufficient. Occasionally, because of their highly echogenic nature, one can determine the location of the copper IUDs transabdominally. Usually, though, we use transvaginal sonography, and when using 2D ultrasound, very careful scanning in multiple planes that are sagittal to the endometrium as well as coronal to the endometrium to try to recreate, as it were, in our minds, the configuration of the IUD. 3D ultrasound can be especially helpful for women with the difficult to visualize Mirena. Finally, recording a cine clip can be helpful for study after the examination to assess the position of the IUD. What are the complications and findings of IUDs? Myometrial penetration or embedment may decrease the contraceptive effectiveness of the IUD and may be seen in conjunction with pregnancy. The embedded IUD is usually removed, and it may be removed with some difficulty, and it may require the patient to be taken to surgery. Expulsion can be partial or complete. Abnormal position, fragmentation, pelvic infection, and finally pregnancy, intrauterine, and ectopic need to be searched for. Now, here's an example of a case where the IUD is located in the cervical canal, and when the IUD is in the cervical canal, it is less effective as a contraceptive, and here we see that there is an early intrauterine gestation. Here is a 3D image showing that the long stem of the IUD is embedded into the cervix. Here is the short stem of the IUD in the cervical canal, and the other short stem is located in the upper cervical canal. Here another example of an IUD. The long stem is in the cervical canal and the short stem is perpendicular to it, coming out at us, embedded in the lower uterine segment in the presence of an intrauterine pregnancy which progressed normally. Uterine perforation is the most serious complication of IUD, and the literature shows that the frequency varies between 0.05 and 13 per thousand insertions. The frequency varies with the factors related to the patient, the operator, and the type of IUD. It is important to be aware of the fact that approximately 15% of IUD-related uterine penetrations lead to serious complications in adjacent visceral organs, primarily the intestines. So obstruction, penetration, intestinal infarction, mesenteric injury, rectal strictures, and rectouterine fistulas have all been described as complications of uterine penetration by intrauterine devices. Now, here are some 3D images of a normally placed T-shaped Paragard IUD. Here are the horizontal stems and the vertical stems. Here in the coronal plane, again, this IUD is in optimal position. With 3D ultrasound, one can also use the multi-slice display where we have multiple parallel slices in the same orientation. And we can see here another T-shaped IUD. Notice that one of the horizontal arms is located in a slightly different plane than the other arm, but by going through the slices, one can determine that the IUD is intact and in fact is in a good location, as is this T-shaped IUD. Another Paragard IUD in a normal location. Here we see the characteristic double echoes of the horizontal arms, and with the rendered 3D image we can actually see the string of the IUD as well. Here is a copper T-shaped IUD in a patient with an arcuate uterus, so it is a little bit lower than ideal, but given the fact that she has an arcuate uterus, this is probably an acceptable location. Here a slightly older case, an IUD that appeared in the sagittal plane to be either normal or slightly low in position. When we explore the location of this IUD using 3D sonography, we note that there is the shadow of the long stem here, and then when we manipulate the volume further, we can detect that there is embedment of one of the horizontal arms into the myometrium of the lower uterine segment. Here's an example of a Mirena IUD that is in the uterine cavity, but in which the very echogenic string simulated the IUD being in the cervix. So these are the initial 2D images, and we have a highly echogenic structure in the lower uterine segment and cervical canal. There were just a few little echoes, foci of shadowing in the upper uterine cavity, and the initial impression was that this was actually an IUD on its way out. But further evaluation with 3D ultrasound was very helpful because we could use the artifact, the shadowing from the Mirena, which itself is not terribly echogenic, but we could use the shadowing to image it. And here we see that the Mirena is in fact in a very good position, and what we were seeing was the echogenic string. So sometimes it's necessary to use the artifact from the IUD to actually confirm its position. This woman had some abnormal bleeding and a history of polyp, and the concern was, is the IUD causing the intermenstrual bleeding, or is there another polyp? And here we see in the coronal plane, pointed to by the yellow arrow, that there is minimal myometrial embedment or penetration by this horizontal arm. We actually performed a sonohysterogram to assess the cavity because there can be some difficulty assessing the cavity in the presence of the IUD. and demonstrated that there was no polyp, confirming the myometrial penetration here. And the clinician was pleased as long as there was no polyp. The intermenstrual bleeding itself was not clinically significant. Now here is an example of the Mirena IUD. Notice that there is a curvilinear bright echo in the cervical canal. Then when we get to the uterine cavity, we see multiple parallel echogenic lines and extensive shadowing in the sagittal plane. And then when we come into the coronal plane, we have some shadowing from the long stem. And then these are the horizontal arms in a coronal cut through the upper uterus. Again, we have the double echo, but the other arm was not in the same plane and somewhat difficult to see, and therefore our confidence was not great that in fact we could say that the IUD was in perfect position. But again, using the shadow of the IUD to image the IUD on 3D ultrasound, we see that in fact the IUD is intact and is in a normal location. Here again is the echogenic string. Here another example of the string looking very echogenic, some shadowing from the long stem of the IUD. In the coronal plane, very difficult to see the horizontal arms of this Mirena IUD. Here is a cine clip which can be helpful. Again, we see some shadowing from the long stem of the IUD, but hard to be sure about the horizontal arms, although we can see some punctate echogenic foci as we go through it. Again, much easier and more confident identification of this IUD using the 3D ultrasound. There's no question that this is nicely placed in the endometrial cavity. And here is the string that had withdrawn into the uterine cavity and therefore was not clinically palpable. This 32-year-old woman came in with abdominal pain. You can see here on the topogram from the CT that she has a Mirena IUD. The CT can tell us that the IUD is in the general vicinity of the uterus here in the lower uterine segment, but does not give us precise information about the location of the IUD with respect to the uterine cavity. We see in this case that there is some infiltration and streakiness of the pelvic fat, and in fact she had an acute early PID. Another example of a woman that was referred because of a lost IUD string. In this case, the IUD is highly echogenic with shadowing. This is probably a little bit of the string. The horizontal arms here are seen nicely, not much question. In this case, with 3D ultrasound, though, we can see what happened to the string. It didn't break off, but it's curled up in the uterine cavity. And here a plain film on a woman. Again, the question was, is the IUD outside of the uterus? Because the string could no longer be palpated. When you look on a plain film, you know the IUD is someplace in her body, in the pelvis, but you really can't say where it is because we can't define the location of the uterus. Here on ultrasound, we see the echogenic string. Again, we see the linear, multiple linear parallel lines that represent the vertical stem of the IUD. The Mirena, the horizontal arms are here, but difficult to see with confidence. Again, a 3D ultrasound showing that the IUD is in a good position. Keep in mind, again, one needs to remember that the distal aspects of the horizontal arms of the Mirena are bent inferiorly, and you don't want to call that a broken IUD. Now here's a topogram from a CT in a woman with a copper T IUD. You see it's much more radio-opaque. She presented with abdominal and pelvic pain. Here we see that there's some beam hardening artifact related to this metal IUD. Notice, again, we can say that the IUD is someplace in the uterus, but very hard to judge on CT exactly where it is because we don't really see the cavity distinctly. Unfortunately, in her, on ultrasound, we see that this copper T IUD is located low. It's in the lower uterine segment and in the cervical canal, the upper cervical canal. And in this case, we demonstrate an artifact which mimics fragmentation of the IUD. This is the long stem here, seen in cross-section with shadowing, and we actually see 4 echogenic structures radiating around the long stem. And the first time that one observes this, it can be rather confusing. Has the IUD become fragmented? What's going on here? Is there more than one IUD? This is a video clip. Notice that of these 4 echo densities, 2 of them are more echogenic and 2 of them are less echogenic. In fact, this is an artifact related that one sees with the copper IUDs. These artifacts can mimic fragmentation and should not be mistaken for an abnormality. There are quite a number of articles in the literature recently in the last couple of years because of the increased use of IUDs both for contraception as well as for the treatment of abnormal bleeding, and I encourage you to become familiar with these other applications of the IUD because you will be seeing them in perimenopausal and menopausal women and in women being treated for endometrial hyperplasia. And there the concern is not so much contraception as it is making sure that the IUD is in place in order to effectively treat the problem. What next? What if an IUD is known or thought to be present but not visualized sonographically? Further evaluation may include a plain film, which will document the presence of an extrauterine IUD but not the exact location. CT will show the general location of the IUD and of course is very good for identifying associated complications. Finally, a comment about the MRI. MRI can show the IUD as a signal void. Keep in mind that the safety of all of the metal-containing IUDs at the high field strength of 3T has not yet been proven. So in conclusion, intrauterine devices are increasingly being used for reversible contraception as part of hormonal replacement therapy and as treatment for excessive uterine bleeding and endometrial hyperplasia. There is a lot of excitement regarding the application of the IUD for the latter indications because we may be able to reduce the need for endometrial ablation and hysterectomy. Ultrasound plays a critical role in the evaluation of patients with IUDs. It is incumbent upon imagers to be familiar with the appearance of IUDs and the pitfalls in their imaging. And finally, 3D ultrasound may add significant information that can affect clinical management. Thank you.